Hey, thank you so much for joining us today. We're going to be talking to you a little bit about ARFID and applying a family-based treatment model to ARFID. And the title of this presentation is ARFID Meet Family. Our presenters today will be myself. My name is Megan Hellner. I am Equip's Nutrition Director. And Tana, I'll have you introduce yourself.
Hi, everyone. Thanks so much for joining us today. I'm Tana Luo, Director of Therapy here at Equip.
Okay, thanks so much, Tana. So we have the following objectives. We hope that you'll be able to, by the end of this, identify the three primary ARFID presentation types commonly seen in clinical settings. We'd like you to also be able to name three treatment goals of FBT for patients with ARFID. And finally, we hope that you'll be able to describe two types of exposure-based interventions that are commonly used when we're working with ARFID patients. As our agenda for this presentation, I'm going to start off with a brief overview of the diagnostic criteria for ARFID from the DSM-5, and we'll include just a general review of the epidemiology, a little bit of history of how ARFID came to be a diagnosis as well, and I'll wrap up by running through of the self-report measures that are used to assess ARFID before turning it over to Tana. Tana is going to lead the discussion on evidence-based treatment options for ARFID and talk briefly about the importance of the multidisciplinary team approach. And she'll finish up with a case study, and then after this live recording, or after this recording, we'll join you for a live Q&A session. Okay, so a little bit of a history on ARFID, and then we'll go into the diagnostic criteria. So, ARFID was officially added to the DSM-5 in 2013 as an eating disorder subtype. Prior to that, ARFID-like behaviors were typically referred to as by clinicians as picky eating, or perhaps they fell under the category of food phobias or having sensory issues with food, or perhaps even food aversions. These were often diagnosed as eating disorder, not as otherwise specified when that was an eating disorder subtype, or a feeding disorder of early childhood. It can be easy, therefore, to minimize ARFID symptoms and kind of chalk this up to normal childlike behavior, as many kids display picky eating or selective eating behaviors. But try to think of ARFID, I often refer to it as picky eating on steroids. Many patients and parents have kind of delayed in getting help, or they haven't been able to get help because the symptoms are minimized or written off as picky eating or selective eating. And then by the time the ARFID is addressed, the child might be quite entrenched in their eating disorder, or perhaps it's been kind of so long-standing that growth and development have been unfortunately compromised. So just a bit about the diagnostic criteria for ARFID. This is an eating or a feeding disturbance as manifested by persistent failure to meet nutrition needs or energy calorie needs. Associated with one or more of the following. So a significant weight loss or failure to kind of track along their expected growth trajectory. This may be a little bit tricky for parents to pick up on if the child is not losing weight per se, but in fact, they're just really not kind of tracking with growth and development. Weight isn't increasing at the rate we'd expect it. The second one is significant nutritional deficiency. This refers to both micro and macronutrients. So your macronutrients are your calorie-containing nutrients, your carbs, fat, and protein. Dependence on enteral feeding, which is otherwise known as tube feeding, or oral nutrition supplements like Boost or Ensure, and or a marked interference with psychosocial functioning. And oftentimes this is kind of the thing that helps parents to understand where this starts to deviate from just kind of run-of-the-mill picky eating. Number two, the disturbance is not better explained by lack of available food or cultural practices. So examples of this might be food insecurity, where someone just doesn't have access to adequate food, or as far as like a culturally sanctioned practice, maybe we're thinking about fasting in this case. Number three, the eating disturbance doesn't occur during a bout of anorexia or bulimia, and we're not seeing issues with the way that body weight or shape is experienced. So one really important differentiating factor for ARFID is there's not typically that fear of intense fear of fatness or a fear of weight gain. And number 4, the eating disturbance is not attributable to a concurrent medical condition or not better explained by another mental disorder. So what comes to mind here is maybe someone undergoing treatment for cancer and perhaps they have anorexia or a limited appetite because of the chemotherapy or radiation. That wouldn't be considered ARFID or an eating disorder per se, so with the exception here being when the eating disturbance occurs in the context of another condition and the severity of the eating disturbance exceeds that you would typically see associated with that condition, then it would warrant attention. A little bit about just kind of prevalence and epidemiology of ARFID. This is just kind of a general overview. We don't have a lot of reliable information because, again, this is a relatively newly recognized eating disorder subtype as of 2013. But the population prevalence, there's a big range here, is expected to be somewhere between 0.3% and 3.2%. This can occur at any age, though we typically see this popping up in childhood. It's really hard to diagnose with certainty between the ages of 0 and 5, just because some kind of picky or selective eating can be age appropriate. And rates of ARFID may be more similar across genders compared to anorexia nervosa, although we don't know too much about this yet. As far as psychiatric comorbidities, we also a very wide range here, somewhere between half to nearly 100% of ARFID patients seem to have at least one psychiatric comorbidity. 10 to 25% seem to have 2 or more, and most commonly we'll see anxiety as that primary psychiatric comorbidity, or other mood disorders about 1/3 of the time, and ADHD roughly, between 4% and 26% of the time. There's not a lot of reliable research at this time on how the psychiatric comorbidities are different across the 3 presentation types of ARFID, which we'll be talking about in just a few minutes. Okay, so we have 3 primary presentation types for ARFID, and this is just kind of how ARFID might present in clinical settings. Notice that there's a lot of overlap, and these don't tend to occur in really distinct categories. So first, we'll talk about the fear of aversive consequences. This might mean that the patient endorses a fear of choking or vomiting, or perhaps a fear of foodborne illness when eating foods that are kind of deemed unsafe or new. This might have been the result of some sort of triggering event. For example, a lot of the patients that come to mind when we think of fear of aversive consequences might have thrown up at a young age from eating a particular food, and then they come to really fear that food. And perhaps they engage in other kind of safety behaviors that reinforce the fears of this food, like avoiding eating out of the house. And this may show up as them eating a low variety of foods, a very limited number of safe foods, or perhaps they restrict the volume of food that they're eating because they fear vomiting or choking or getting sick as a result. The second we can talk about is the lack of interest in eating. And this is perhaps associated with someone that has just kind of a low awareness or acknowledgement of their hunger or fullness cues. Perhaps they're very sensitive to GI distress or associated constipation or diarrhea associated with eating would be one example. And this might result in them keeping the volume of food that they're eating very low. Another example that comes to mind is a particular patient that I once saw who was gaming all day and just didn't really respond to hunger cues throughout the day in the same way that another child would. They weren't taking breaks to eat, so weight dropped really low as a result, and certainly the volume of food consumed in a day was really low as well. Selective eating, this might be a characteristic of a kid that is very sensitive to the sensory properties or taste or texture differences of different foods, or they may have a strong brand preference. Perhaps this is the kid that eats only Kraft mac and cheese. We can also characterize this perhaps by being afraid of new foods or trying unfamiliar foods. And this shows up as eating a very low variety of foods. I'm going to turn this slide over to Tana. She's going to talk a little bit about this 3D neurobiological model.
Thanks, Megan. So as Megan mentioned, the three general presentations of ARFID that we typically see aren't so much these discrete categorical subtypes. As the field has gotten kind of familiar with the ARFID diagnosis, I think we often see that there tends to be overlap in the presentations. So Dr. Jennifer Thomas and her group have developed this three-dimensional neurobiological model, which essentially captures the presentations along these different dimensions. So as an example of this, if we're talking about our patients who are fearful of risk of consequences, these are patients that might have certain neurobiological predispositions to that presentation of ARFID. So for example, some of these individuals have a hyperactivation of threat system. So if they are in a situation that creates anxiety, there might be a hyper response to that anxiety provoking stimulus. Likewise, there might be an overgeneralization of fear learning. So by that, I mean, let's say we're thinking about the patient that Megan alluded to, who's fearful of vomiting. So they might initially have an aversive experience with one food item that maybe led to vomiting, and then they overgeneralize that fear learning, and now they're avoiding maybe foods that are kind of related to that initial food item, but other foods as well. And then finally, these are patients who might also experience some visceral hypersensitivity. So they might be really tuned into and sensitive to their interoceptive cues, particularly those related to GI functioning. For our patients with a lack of interest in eating or low appetite, there may be certain hormonal abnormalities within these individuals. So these are patients whose bodies might not produce ghrelin, the hunger hormone, in the way that a patient without ARFID's body would present. These are also patients who can experience visceral hypersensitivity. So again, that sensitivity to GI distress, what's happening within their bodies. They might also have interoceptive deficits. So on the flip side, sometimes not being as in tune to their hunger cues or fullness cues. And then finally, our patients who are selective eaters or struggle with selective eatings, these are patients who might have hypersensitivities in their perceptual systems related to eating. So some of these patients could even be super tasters. So they actually might be extra sensitive to those sensory properties of food. They might also experience certain alterations in taste receptors. And there's some emerging evidence that disgust might play a role specifically for patients who are selective eaters. So they might be extra sensitive to disgust, and they might be extra responsive to disgust, particularly when it comes to food.
Thank you so much, Tana. Okay, so for this slide, we're just going to talk a little bit about some of the nutrition-related consequences of ARFID. And the first thing I'd want to say is that poor nutrition or malnutrition or undernutrition, can be called a number of things, affects all of our organ systems. And we see this across eating disorder subtypes to a similar degree. For example, the bone loss that we see in anorexia, there's some emerging evidence that suggests that it's just as problematic in ARFID, or that folks with ARFID are at just as high a risk of developing osteoporosis or osteopenia as their counterparts with anorexia. Failure to thrive or delayed development is something that we'd often see, especially because this is occurring in younger kids and is often kind of enduring, or there's a really long duration of illness. So what that means is that they tend to fall off their growth curves. If we look at where they were kind of tracking prior to beginning to struggle with food, we might see them kind of drop from the 75th percentile to the 25th or the 20th or the 10th percentile when we're looking at like those age-adjusted BMI growth charts. And that can not only affect their weight trajectory, but it might also compromise their ability to kind of reach their peak potential height. 1/4 of patients are hospitalized due to unstable vitals or low weight and associated medical instability. And then we'd also see micronutrient deficiencies and the associated symptoms. So it's not uncommon in this population to see low vitamin D, iron deficiency, a folate deficiency if they test for that, B12 related anemias, or other things like even a vitamin C deficiency and scurvy, which is something we don't typically see nowadays in the developing world, or vitamin A deficiency and related issues with vision. That's also something that we don't see a whole lot in the developing world. So it's also important to know that a lot of these things aren't tested for in most clinical settings unless explicitly requested. And even then, we don't have tests for all vitamin deficiencies that are reliable and accurate. So sometimes we're really relying on kind of reports of what they've eaten in a typical day or what they're eating now to be able to kind of guide our supplementation efforts. Or we also might see a dependence on, again, nutrition support, which could be either IV nutrition or usually it's tube feeding or enteral feeds, and the oral supplements that we mentioned, like Booster and Sure. Consequences of that are, several-fold if they're not able to meet their nutrition needs just through their oral intake, through kind of normal intakes of foods. That has also serious psychosocial implications as well. Impaired immune function, if they're not able to meet their needs, is also a concern. And then GI issues, not limited to these, but these are some common ones: reflux, gastroparesis. Just think of that as very, very slow digestion, slow gastric emptying, and constipation, just to name a few. And that might be because of the low intake or just the poor quality of diet. Inadequate fiber intake can contribute as well. So we've talked a little bit about a few psychosocial consequences, and this is something that we often like to cite when we're trying to highlight the seriousness of ARFID with families who are kind of just used to this as the normal for their kiddo. Social isolation, again, it is typically not the case that it is comfortable for a kid struggling with ARFID to go out and join their peers. With meals, they might have gotten a lot of kind of feedback socially that the way that they're eating is unusual or weird. So perhaps they're more inclined to eat only at home with family or just even by themselves. A lot of family conflict and frustration around meal times, as you can imagine. If you have a kiddo that's just eating 1 or 2 or 3 or a handful of safe foods, it's really frustrating and worrisome for the family that they can't all eat together or eat the same foods. Exacerbation of existing psychological issues, whether that's something like OCD or anxiety. The malnutrition tends to make these things just worse or more exaggerated. There can be issues with focus or concentration, as you can imagine, when a kiddo isn't well fed or consistently fed. That tends to show up in the way that they're able to take in and retain information. We can see developmental delays, again, in part as a result of the malnutrition or undernutrition. We just don't know a whole lot about the long-term outcomes, given that this is often a disorder that presents in childhood and given that it's a relatively new diagnosis as of 2013. So keep that in mind as well. A little bit more on nutrition support. When we use the word nutrition support in the nutrition world, typically we're talking about tube feedings or IV, the use of IV nutrition or oral supplements to supplement or support someone's oral intake or regular intake. What we hope is that if we are needing to lean on tube feedings or the use of supplements for these kids or these patients, the hope is that it kind of awakens their appetite a little bit, and that they're able to eventually transition back to a regular diet, and they're able to kind of fully meet their needs through a regular diet as soon as possible. Having said that, it's we can think of the option of nutrition support as life-saving for some of these patients that are not able to meet their needs through an oral intake. It can be considered sort of I guess kind of like radical. I've heard people refer to tube feeding as force feeding at times, but we have to remember that this really is like a life-saving and helpful option for folks that aren't able to, again, eat enough to grow and to develop as they normally would. We don't often see these patients on IV nutrition, although that is an option, just because of that mantra of if the gut works, we want to use it. So we would typically go the route of tube feeding before we would turn to IV nutrition, in this case, to supplement their intake. The dependence on products like Boost or Ensure is really, really common, and I think it can be seen as an easy alternative for folks who are struggling with new foods or fears of vomiting, fears of choking, just because it's reliable. They taste relatively good. They're bland. They're safe. There's often not the fear of foodborne illness when you have like a contained bottled product like Ensure or Boost or some other shake. So it can be kind of I don't want to say an easy alternative, but a safe alternative to having to grapple with like new foods or expanding variety. Parents also tend to develop somewhat of a comfort level with it, just because at least they know that they're kind of getting their needs met as far as calories, vitamins, and minerals. Dietary supplements are usually indicated, but it depends on the presentation type and some other factors. Our preference is always that they're able to meet their needs through the food. I mean, that's generally the goal of eating disorder treatment. But of course, that's easier said than done, and it takes time to get there. So it may be the case that we just want to start off with some kind of basic and general dietary supplements like multivitamins or supplemental vitamin D, calcium, iron, or vitamin C, just kind of depending on what kind of gaps are showing up in this kid's intake. So I think it's probably worth spending just a little bit of time talking through some of the similarities that we might see when we're in these kids that are presenting with either ARFID or anorexia. First, both can be treated using family-based treatment approaches. Initially, I think most of us, when we think of treating anorexia nervosa, we think of using family-based treatment, but this has now been adapted successfully for treating other eating disorder subtypes as well, ARFID being one of them. Also, often we can use behavioral contingencies, and Tana will be talking a little bit more about this later, to kind of reinforce compliance when we're using family-based treatment, although this may look a little bit different in how we would recommend doing this with folks with ARFID versus anorexia. Also, in both cases, we would see weight loss, typically in anorexia, and certainly with ARFID as well, although we won't always see weight loss with ARFID. And the complications as far as the consequences of the malnutrition or poor nutrition look really similar in ARFID and anorexia. One of those being, again, the risk for bone loss. There's a limited number of safe foods in both of these cases. So there's kind of a small repertoire of foods that these individuals are consuming. Lots of conflict or stress in the family around meal times and snack times. It's in both cases socially isolating, although for different reasons, and it's poorly understood by peers. It's often minimized and not properly diagnosed in medical care settings, and that's especially true of ARFID because, again, it can be kind of written off as sort of age-appropriate picky eating, and therefore there may be a really long delay before the family is able to get specialized treatment. Corresponding GI issues can be really similar. One that comes to mind is usually constipation because of either a poor quality of diet or just very low intake. It requires a specialized team that really knows eating disorders to treat effectively. And in both cases, you might see kind of an exacerbation of their existing psychological issues. So for example, if they had anxiety or depression prior to the eating disorder onset, we would expect those to get markedly worse through the course of their illness. Noteworthy differences between ARFID and anorexia. So how do you know kind of if you're seeing a patient that might be struggling with one of these, how are you able to kind of tease them apart? When we're talking about ARFID, again, one of the hallmarks is there's typically no disturbance in the way that weight or shape is experienced. So they may not be resistant to weight gain or have kind of a fear of fatness. And that's kind of a hallmark of anorexia. The age of onset is typically younger with ARFID, and they may have struggled for longer. Perhaps this patient is in their teens and they've kind of had ARFID since they were 2 or 3 years old. It's more prevalent in males, which is unusual and different from anorexia. And the meaning of safe foods is different. Perhaps a safe food for someone with ARFID is a food that doesn't present as a choking hazard. And that's not something that we would see in anorexia. The safer food might be the one that is lower calorie or regarded as healthier. There may be, again, less resistance to the idea of weight gain, or even less resistance to the idea of treatment in general. They may be kind of more on board with the idea of having the support of a team to get through this. They may respond differently to behavioral contingencies. It might be more effective to use rewards for patients with ARFID to kind of motivate compliance and motivate them to push through meals than it would be for someone with anorexia, who is really entrenched and kind of bought into the restriction. The criteria for movement across the different phases of family-based treatment is different, and that's something that Tana will be talking about a little bit later on. And with ARFID, the quality of the diet tends to be very poor, and you may or may not see, the patients may or may not be intaking a really low number of calories. So it's not uncommon for folks with ARFID to have a calorie intake that isn't especially low, but perhaps they're only eating 2 or 3 foods. And again, the overall quality of the diet is really, really poor. So we're going to talk through just a few of the self-report measures that are available for folks struggling with ARFID. The first one is called the PARDI, P-A-R-D-I, and this is an 83-question kind of Likert type scale that measures the ARFID symptoms and can predict an ARFID diagnosis, as well as the severity of the impact of ARFID symptoms for each of the 3 presentation types. There's a parent version available for ages 4 plus. Otherwise, the patient version is appropriate for kids that are 14 years or older. The EDYQ is a 14-item 0 to 6 going never to always self-report measure for ages 8 to 13. And the 12 items cover ARFID symptoms and profile types. The last 2 cover pica and rumination disorder. And the NIAS, this is one that we also use. We use, I think, NIAS and EDYQ in our program, is a 9-item Likert scale self-report measure that has cut points that will tell us a little bit about that primary ARFID presentation. There's a pediatric version for 8+ and an adult version as well. And finally, the always sometimes never list, not exactly an assessment measure per se, but this is something that our dietitians give in that first session that helps us just sort of understand the landscape of their intake. They're kind of rating or listing foods that the child eats often, foods that the child eats with some difficulty, but will eat sometimes, and then there'll be kind of a category for foods that the child never eats. And that just helps us understand how to approach reintroduction of some of the fear foods. Okay, now I'm going to turn it over to Tana, who's going to talk to you about evidence-based treatments and best practices.
Thank you, Megan. So right now we have 2 manualized treatments for ARFID. So one is CBT for ARFID and one is FBT adapted for ARFID. So in CBT for ARFID, there are 4 primary stages of treatment. In stage 1, the clinician is providing psychoeducation about ARFID, as well as helping the patient to establish a regular pattern of eating. So for patients who are underweight and require weight restoration, there's also a focus on increasing the volume of intake in order to promote weight gain. For patients who are not underweight, who do not require weight restoration, the focus is really on establishing a regular schedule of eating, and we might start to focus on an initial increase in variety of eating. In stage 2 of CBT for ARFID, we're continuing to focus on renourishment while also laying the groundwork for the patient to start trying some new foods or unfamiliar food items. In stage 3, depending on the patient's presentation of ARFID, the clinician might engage in different types of exposures to target specific symptoms. So for example, a patient who struggles with fear of aversive consequences might be engaged at this point in some exposure and response prevention to directly target those symptoms. And then finally, in stage 4, the clinician focuses on relapse prevention planning. I'm going to be focusing mostly on FBT that has been specifically adapted for ARFID, and I'm going to dive in a little bit deeper into the different phases on our next slide. Okay, so FBT for ARFID has been broken down into 3 general treatment phases. So in phase 1 of treatment, we're primarily focusing on weight restoration and the normalization of eating. So for those patients who are underweight, really working to, again, increase that volume of intake and to get our patients on a regular schedule of eating. We may also be focusing on dietary expansion, increasing volume of intake for those patients who struggle with low appetite or low hunger, as well as reducing anxiety around eating for our patients. In phase 2, the focus is really on returning developmentally appropriate independence back to the patient. So whereas phase 1, parents might play a greater role when it comes to establishing that regularity of eating and helping the patient to expand their variety or increase their volume of intake. In phase 2, we're really starting to work on how we get developmentally appropriate independence back to the patient. So whether the patient is a child, an adolescent, a young adult, or well into adulthood, the focus would be helping them with independence. And phase 3 is all about relapse prevention planning. So looking ahead and making sure that the patient and the family have a solid plan in place in order to catch backslides early on in order to prevent them from turning into relapses. In phase 3, we might also start to shift our focus of treatment. So rather than really honing in on eating specific symptoms and addressing those symptoms, we might start to focus on other developmentally salient themes and tasks of adolescence. Okay, so a little bit more about phase 1 of treatment. So again, the goal here is weight restoration or regulation of eating behaviors. So a couple of the interventions that we might use here. I think Megan talked about the always, sometimes, never list. So based on that list, we can collaboratively with families identify foods that the patient is able to consistently eat. So foods that would kind of fall into that always category. So when we're focusing on weight restoration, we might help our parents to help their child increase the volume of those preferred or always food items. So when we're in this phase of treatment, we might not be as concerned with increasing variety of intake, focusing on those never foods, but really just looking to increase the volume of intake of preferred food items in order to promote weight restoration. Oftentimes, parents also need some support in increasing the structure or supervision around meal times. So we know that all of our ARFID patients probably experience some level of anxiety or distress around eating. They might not experience an intrinsic motivation to increase their volume of intake. So parents may benefit from support from their provider team when it comes to structuring those meal times, and again, making sure that there's oversight of meal times and snack times in order to increase intake in their child. At this stage, clinicians are also providing a ton of psychoeducation on why we want to establish that regular schedule of eating. So primarily thinking about our patients who might struggle with low hunger or low appetite, super important to get on that regular schedule of eating, because as the patient starts to eat at regular times during the day, the body will anticipate that a meal is coming, and then the body will produce that hunger hormone ghrelin. We're also providing psychoeducation on the role of avoidance or safety behaviors in driving and maintaining food-related fears. And we might also be starting to lay the groundwork for the use of exposures in order to increase dietary variety. So providing psychoeducation about why we might use exposures to target these symptoms. And finally, as I mentioned earlier, a lot of our patients might not be intrinsically motivated to increase their volume of intake. So parents may also benefit from implementing behavioral reward systems in order to motivate eating. For younger patients, this might look like using sticker charts or token systems in order to shape eating behaviors. But I've also worked with some older adolescents who tend to respond really well to token types of systems. So this is a place where you can really collaborate with the family to figure out what type of behavioral reward system and what type of reward structure would be motivating for their child. Some specific interventions for selective eating. So on the next couple of slides, I'm going to be going through those 3 general presentations of ARFID and some interventions that can be used for each presentation. So this is going to be all about selective eating. So the first goal here is to increase flexibility with preferred food items. So it's not uncommon for patients with selective eating to demonstrate food jags, and particularly in our younger patients, we see this quite frequently. So food jagging being a food jag being a patient kind of honing in on one food item and only eating that food item and excluding all other items, even if they have other foods that they would be able to tolerate. So we want to work with parents to increase flexibility within those preferred items. So almost keeping like a rotation of different preferred food items so that the patient isn't just eating one item. An example of this is I worked with a patient who struggled with selective eating and initially came into treatment really only eating one brand of waffles for breakfast. So the first thing that we did with this family was to introduce one other item into the rotation. So for a little while, that patient was having just waffles and just croissants. So we kind of alternate back and forth those 2 breakfast items until he got comfortable with that and we were able to include some more items into the mix. So we can start really low and slow when it comes to flexibility, and then again, like adding more foods to the repertoire. At this stage, we're also starting to do some graduated exposures for the introduction of novel food items. These exposures can be done in session, and we really recommend that families continue to present novel food items at home. So for there to be quite a bit of at-home practice so that we're increasing the number of novel food exposures that the patient is doing. When it comes to what foods to present, this is a very collaborative process with the patient and the family to decide which foods we want to work on. So there might be some patients who are actually motivated to expand their variety. So I'm thinking about an older adolescent who might be experiencing a lot of social impairment as a result of selective eating and maybe really wants to be able to go out to a restaurant with their friends and be able to eat something off the menu. So if that's a goal of the patients, then we might work to identify like, okay, what are some food items that we could probably find on most menus at most restaurants, and let's start there. We might also focus on food items that would increase the functionality of eating. So maybe the family identifies that school lunches are really difficult and they just can't find something that the patient can bring to school and eat reliably at school. So that would give us a clue to look at lunch items and things that would be easily packable to bring to school, or food items that are commonly available within school cafeterias. So again, really working actively with the patient and the family to figure out which foods we even really want to work on. 2 particular strategies for introducing items are shaping and chaining. So the idea here is that we're gradually increasing the presentation of unfamiliar food items, and we might be able to link more familiar or preferred food items to unfamiliar food items, and then slowly scale up the portion of the unfamiliar food item. And I'm going to go into this in a little bit more detail on the next slide. So the idea with shaping is that we are slowly shifting our practices around meals and snacks in order to be able to expand the variety of foods. So this is similar to what we discussed when it comes to some of the strategies that we would use to increase volume of intake. So this might mean setting certain expectations around meal times or using behavioral contingencies in order to shape eating. An example of chaining might be, so let's say a patient is comfortable eating muffins and can eat a variety of different types of muffins. Then we might move to a food item that is similar to muffins, but is also different in some ways, like scones. One way to chain might also be to identify a certain element of a food item that is safe and to keep that thing consistent over time. So let's say a patient is able to do chocolate chip muffins and is really, really comfortable with chocolate chip muffins. When we introduce scones, we might introduce chocolate chip scones to start. So it's a food item that's similar enough, but also different. Then we might expand from there. So maybe we expand to a different type of scone. Maybe eventually we move to something like a croissant and so on and so forth. Another example might be, let's say a patient is really comfortable with mac and cheese. That's one of their preferred food items. We might pair a somewhat familiar vegetable. So let's say they do okay with cooked peas. We might mix in some peas into mac and cheese. So there's a large proportion of the preferred food item and then a small portion of a familiar vegetable. And then as the patient starts to develop some level of familiarity and comfort with the peas, then we increase the amount of peas that are in the mac and cheese, maybe eventually serving the peas on their own. One thing to note here, and can be really helpful to stress to families, is that it can take anywhere from 10 to 50 presentations of a new food before it's no longer perceived as scary. So the reason I want to highlight this is sometimes families might present a food item once or twice. Maybe the patient doesn't really take to that food item, and families might have an urge to just kind of scrap that food item and move on to the next. But we know that it can sometimes take, again, up to 50 presentations of that new food item. So we want to help our families persist to some degree with these presentations, knowing that the more the patient tries that food, the more they'll acclimate, and the higher the likelihood that they'll be able to actually incorporate that food item. Some other examples of chaining and shaping, I won't go into these in too much detail, but just more kind of visual representations of how we might chain to a goal. Okay. For our patients who struggle with fear of aversive consequences, we also have a couple of specific interventions. So we might first start with some anxiety reduction strategies. So if a patient is really struggling with heightened anxiety during meals and snacks, we would work with the family to identify certain skills or distress tolerance tools that would be helpful in regulating that distress. So some go-tos here would be diaphragmatic breathing, as well as progressive muscle relaxation. I've also worked with patients who seem to respond really well to imagery. So this is a time, again, where you can really actively collaborate with the family in order to identify what are the things that are going to work the best for their child. I think we can also really lean into what parents know about their kids here. So we might engage parents in a conversation about, in other situations where your child has felt anxious, maybe not in response to food, but maybe in response to school, what have been some helpful strategies to lower their anxiety? So really pulling from the parents' expertise and what they know about their child. Another primary intervention for fear of aversive consequences is exposures to feared stimuli. So with exposures, we are wanting our patients to practice facing the thing that creates anxiety, and for them to start to learn that the thing that they're worried about happening, let's say it's choking, is probably unlikely to happen. And even if something kind of uncomfortable happens, like let's say they get a kind of a tickle in their throat, maybe food becomes like temporarily like lodged on the way down. So even if something kind of scary or uncomfortable happens, that they're able to tolerate that distress as well as some of the physical discomfort. So when it comes to exposures, we might use a blend of imaginal exposures, so imagining that that feared outcome is happening, interoceptive exposures, so exposing a patient to scary interoceptive cues, as well as cue-based exposures, which can include food exposures. Um, we might be able to use some anxiety reduction strategies at the beginning of exposures, but we also want to be really careful that those anxiety reduction strategies don't then become safety behaviors. So as we move forward with exposures and the patient is starting to develop a certain level of comfort or mastery with the exposures, we're then going to really work on reducing the use of those anxiety reduction strategies in the context of exposures. Really important note here for exposure work is between session exposure practice with family members is critical when it comes to progress. So if we're thinking about doing an exposure in session just once per week, that is just not going to reach the level of frequency that we need in order for a patient to really overcome their food-related fears. So we really advocate for having family members in exposure sessions so that they can actively be a part of the exposures. And then in between sessions, when they're not in a session with a provider, parents are still feeling well equipped to be able to help their child practice facing their fears before the next time they see their provider. So just to kind of sum up the goal of exposures, so we're teaching individuals that their feared outcome is unlikely to occur. So even if a child is convinced that if they eat that tortilla chip, they're going to choke, we can show them via the exposure that they can actually eat 3 tortilla chips and not choke. So that provides for some really powerful learning that what they were worried was going to happen actually didn't happen. We also want to teach them that they can tolerate distress. So even if anxiety gets really high and they feel like that feared outcome is going to happen, that they can tolerate that level of anxiety. They can also tolerate those uncomfortable physical sensations. So just because there is discomfort in the throat, or let's say discomfort in the stomach, doesn't mean that they're not going to be able to stand it, that they can actually tolerate those different sensations, and that both anxiety and discomfort are temporary. So we also want to help our patients stick it out with exposures so that they can also learn that even though anxiety is at a 10 out of 10, if we just stick it out, that anxiety will probably come down to a 7 out of 10, then maybe a 5 out of 10, and so on and so forth. Specific examples of types of exposures that we might utilize with patients who are fearful of aversive consequences are writing and reading a script about the feared outcome, so choking, vomiting, foodborne illness. For those patients that might be fearful of vomiting, if they feel full, we might have them practice taking one bite beyond that feeling of fullness. We can have patients watch videos of the feared outcome happening. So again, the idea is to help the patient learn that just by doing these things, their feared outcome probably isn't going to happen and they can tolerate distress. Okay, and finally, some specific interventions for low appetite or lack of interest presentations. So we're working actively with families to continue to establish that regular schedule of eating, continuing to provide that psychoeducation about why regular eating promotes hunger cues, using behavioral reward systems to shape eating. So using something like a sticker chart or a reward system to motivate eating. Diaphragmatic breathing can be really helpful for these patients as well, particularly if they struggle with early satiety or feelings of fullness. So using diaphragmatic breathing in response to those feelings of fullness, or if they're experiencing any GI distress. And finally, we can also use exposures here for patients who struggle with early satiety. So some examples here would be to take one bite or more, take one more bite or one more sip after reaching the point of fullness. And the goal is to really violate those expectations about the patient's ability to tolerate discomfort. So the mechanism when it comes to interoceptive exposures is really similar to the mechanism that we discussed in the previous slides for our fear of aversive consequences patients. Okay, so that was all phase one. So all of that intervention can happen in phase one, and a patient may be ready to transition into phase two if they are approximately 90% of their target weight range, or at least are making progress towards weight restoration at a pretty consistent rate. They're consistently eating an adequate volume of foods for weight gain. They're trying some new foods, and they're consistently eating with reported reduced anxiety. So once a patient demonstrates readiness for phase two, then the focus is to work actively with the patient and family to increase the patient's independence of eating. And again, this is all based on the patient's development. So a patient who is 8 years old is probably going to have a different set of goals when it comes to independence than a patient who is 18 years old. At this point, we're also helping our patients start to practice eating in different social situations. So let's say the patient has done a really fantastic job of expanding variety at home. Then we might start to have that patient and family work on trying unfamiliar food items or eating newly incorporated food items in different scenarios, like at school, sleepovers, on a trip, etc. At this point, we're also talking about the reintroduction of extracurricular activities, particularly if some of those activities needed to be temporarily paused in order to facilitate weight restoration. And then finally, in phase three of treatment, we are focusing on relapse prevention planning with the family. So we're working with the family to develop a plan for ongoing exposures. And we are coping ahead for possible transitions that may create stress and may increase urges to restrict or avoid food. So some examples of life transitions would be the transition from high school to college, maybe starting a romantic relationship, really anything that might create a little bit of anxiety where we would want to make sure that there's a solid plan in place to prevent backsliding. And there's also room in phase three to shift the focus a little bit away from just eating to other developmental issues. So maybe as we were really focused on eating, we weren't really talking about the patient's difficulties with establishing friendships at school. So this is also a time for us to, again, shift that focus to things that are unrelated to eating. Okay, so I'm going to talk about the importance of a multidisciplinary team approach. So as with the treatment of, I would say, all eating disorders, it really does take a village when it comes to the effective treatment of ARFID. So when we think about a multidisciplinary team, a medical provider is really key. So a medical provider can assess for the medical stability of a patient and also monitor their weights, vital signs, and labs to ensure that medical stability over the course of treatment. If a patient's variety is limited, so I'm thinking about patients who present with fear of aversive consequences, selective eating, a medical provider can also assess for nutritional deficiencies if that is a concern that we have. And for those patients who are underweight and need to weight restore, the medical provider can also provide recommendations about when to reintroduce physical activity and how to reintroduce that activity. The therapist can support the refeeding process, so actively working with the family to identify ways to shape eating behaviors. Therapists might also be implementing exposure-based interventions, both in session and then helping the family to plan for out-of-session exposure practice. And supporting parents in identifying and implementing different behavioral contingencies that can shape eating. We also recommend working with a dietitian. So the dietitian will do or can do a thorough review of the patient's growth history in order to determine an appropriate target weight range. So for those patients who are underweight, doing a review of those growth charts in order to figure out, based on that growth history, where their body needs to be in order for the patient to be healthy. For those patients who might have certain nutritional deficiencies, or maybe they're at risk for developing nutritional deficiencies, the dietitian may also recommend certain dietary supplements and vitamins. And then importantly, dietitians can also make meal plan recommendations. So if you are working with a patient who is underweight, dietitian might be able to recommend, like, okay, this patient needs roughly X number of calories in order to effectively promote weight restoration. And if you have access to mentors, so these are individuals with lived experience. So either lived experience of having had ARFID and recovering, or supporting a loved one with ARFID, having someone with lived experience on the team to support the family can be instrumental. So mentors can instill hope to the patient and the family that recovery is possible. So this is difficult and recovery is possible. Mentors can also teach and encourage skills use. So using that lived experience, being able to offer up tools that are effective, and supporting the use of those behavioral contingencies. And when it comes to ARFID or the treatment of ARFID, it can be really helpful to have additional collaborators that you're working with. So oftentimes patients with ARFID can benefit from working with an OT or an SLP. There might need to be some collaboration with GI, rheumatology, or allergists. So if a patient is presenting with fear of, let's say, an allergic reaction to peanuts, we would first want to make sure, is this patient allergic to peanuts? Do they have a sensitivity to peanuts? This provides really valuable information before diving into exposure work. We always want to make sure that the exposures that we're doing are being done in a safe manner. And also working with school teachers and administrators. So the goal is for these patients to be able to resume their lives, right? For them to be able to go back to school and thrive. And this might mean having certain accommodations in place in order to make sure the patient is supported at school. So also looping in those school administrators and teachers can be really helpful in service of those goals. Okay, finally, I'm going to go over a quick case example for you all. So this is a patient that I'll be referring to as Heather. Heather is an 8-year-old cisgender girl with ARFID. Prior to the onset of Heather's ARFID, she was described by her parents as a quote unquote good eater, and she ate a wide variety of foods. So by and large, pretty normative when it comes to eating prior to the ARFID. Heather was at school and she heard a story from a peer about someone choking and requiring the Heimlich maneuver. This created quite a bit of anxiety in Heather and led to pretty rapid development of ARFID symptoms. So Heather became fearful that she herself could choke on food and began to restrict her intake by both volume and variety. So she was only eating soft foods. She was also deconstructing her foods. So if she were eating like a bread roll, only eating the inside of the roll, kind of the soft bits of the bread, and avoiding the crust. She was engaging in microbiting behaviors, spitting food into napkins or into the garbage, and excessive chewing. So chewing for up to a minute or two before swallowing a bite of food. Unsurprisingly, Heather lost a significant amount of her body weight over a pretty short amount of time, 12% of her body weight in 2 months. And parents were understandably very concerned and took her to the pediatrician for some extra support. So at that point, the pediatrician prescribed Prozac and referred Heather for eating disorder treatment. At intake or admission to treatment, Heather was completely reliant on oral nutritional supplements. So she was only drinking Ensures and only consuming a handful of safe solid foods. So our primary goal with Heather, given the weight loss, was to weight restore. So in this case, Heather's safe foods were really only the Ensure and a couple of safe solid food items. So to start, the team worked with the family to ensure that Heather was drinking enough Ensure in order to weight restore, and also allowing, of course, for some consumption of those safe solid food items. But by and large, weight restoration was really done on oral nutritional supplements. At this point, Heather was also being taught some anxiety management strategies, so things like diaphragmatic breathing, distraction skills, things like that, in order to help her get through meals and snacks, in order for her to eat enough or drink enough in order to weight restore. This family did opt to implement a sticker chart. So these parents knew Heather really well and knew that she was reward sensitive and would be really motivated by a sticker chart reward system. So worked closely with their team in order to develop that chart in order to shape eating behaviors. And the provider team was providing tons of psychoeducation about anxiety and how certain behaviors can reinforce anxiety. So certain avoidance and safety behaviors can actually reinforce anxiety long term. After Heather weight restored and was eating on a fairly regular schedule, treatment shifted to then increase variety and reduce anxiety related to eating. So this involved weekly in-session food exposures, as well as daily parent-supported at-home practice. So exposures were really a blend of cue-based exposures as well as imaginal exposures. So Heather was reading scripts about choking on food. She kind of started low and slow with her therapist. So first just scripts that didn't include a lot of detail, and then slowly ramping up how anxiety provoking the scripts were. And also having Heather do some exposures related to bite sizes. So one of Heather's behaviors was microbiting. So working with Heather to increase the amount of food that she was able to tolerate in one bite, and helping her to practice swallowing larger volumes of food. So Heather was able to make great progress. So Heather gained a total of 13 pounds and was fully weight restored. By the end of treatment, Heather was also eating 100% of her nutrition by solid food. So all of her nutrition was being taken in via solid food. There was no more reliance on Ensure. We were also able to reintroduce all solid foods that had previously been eliminated due to her fear of choking. So she had a really long list of foods that were being avoided at the beginning of treatment because she was fearful of choking on those food items, and we were able to successfully reintroduce all of those food items. By the end of treatment, Heather herself was also endorsing that she had no anxiety about choking or eating, and her behaviors were really matching up with that self-report. So much so that she was able to discontinue medication under the guidance of her provider. And finally, Heather was able to return to a life worth living. So she was able to return to softball and was able to appropriately refuel for that activity. And at this point, we're going to go ahead and stop the recording and launch into our live Q&A. Thank you all so much.